So welcome, everybody. And unfortunately, I gave it a best try. I put 2 months behind putting together reports in advance for board meetings. And unfortunately, the way things are tracking, November was not that kind to us to be able to prepare something about a week ago that probably will still be valid today. So as a result, myself, Karen Riddell, and Dr. Saad are going to go through the following slide deck and give kind of a snapshot where we are, what's happening locally, regionally, provincially, and also to provide some background about what we're facing and giving some hopefully helpful information to our community regarding the various viruses that are circulating as we speak and that we're concerned about. So this is a consistent, unfortunate story for ourselves, but also across Ontario, across Canada, and pretty much nationally, depending on how many beds you have. But as of 10 a.m. this morning, we were well above 100% capacity at both campuses. What is problematic as a part of this is the fact that we have these patients called admit no beds, A and Bs. And what they are is they are patients who have been admitted in the emergency department, have come to the emergency department, been admitted, but are waiting for an acute care bed, but one is unavailable. So they wait in the emergency department in the various stretchers in the emergency department. As of this morning, and this number actually went up a bit as the day went on a little bit, is we had a total of over 37 admit no beds between our new two campuses. And just to put that into context, is back in 2019 for the same time period between October 1st and today, back then we averaged 7 admit no beds in the morning, patients waiting for a bed. Now we're averaging close to 30. And of course, that number keeps escalating. I was just on a regional call, and that issue is increasing across the provinces. We're not alone with seeing admit no beds at its highest rate. So right now we have, as I stated, 10 o'clock, we had 37 between the two campuses, but that number is actually a little bit higher. At the same time, the one thing we've done very well as a region is our number of alternative level of care. It'd be nice if that was lower, of course, because every single bed is a valuable bed at this moment, but it is low as compared to others across the province. Between our two campuses, it's 34 in total, and probably half of those are waiting for a long-term care bed. So Bill 7, even for ourselves, has created some capacity in Windsor-Essex already. As we proceed, we're hopeful that it will continue to do so, because again, every single bed is a very important bed at this time, especially acute care. So also just give you some stats about patients that are admitted. Now, this is in no way a reflection of what's going on in the community. This is just what we see at our hospital. These numbers are dramatically, of course, higher in the community because they don't have to come to the hospital yet, or hopefully they never have to come to the hospital. So we've had 7 adult patients admitted with influenza, 1 ped patient admitted with influenza. And what Karen and Dr. Saad are going to talk about is RSV, what that means, how one is diagnosed with it, how we might be able to prevent it, and as well COVID. What the concern is, are these 3 viruses are going to start to increase, starting pretty much now. Back 3 months ago, it was projected by the Minister of Health and that it was stated come the start of January, there's going to be 2,400 beds that are needed in excess of what's available, acute care beds across Ontario. And that was when Bill 7 was announced and saying they needed to create capacity, because there was that much, if not more, ALC patients and about 2,500 who were waiting for long-term care. So we needed those beds to be available for acute care patients. Based upon what they're seeing in some tracking of numbers currently, also, again, we talked about this at a previous board meeting, is you look to Australia to see what the influenza season looks like. Influenza season for Australia hit earlier, hit harder, and the admission rates for patients with influenza was higher. So as a result, they've redid some data based upon what we're currently seeing, as well as what was happening in Australia. And we're indicating that we're going to get hit, especially with the influenza RSV, is going to be at its apex during the month of December and not waiting until January. COVID itself, for whatever reason, with respect to their projections, are projecting our worst part of COVID most likely will hit in January still, but our worst part of influenza and RSV will be hitting in the month of December, pretty much right around Christmas time. And that's what's projecting now. And unfortunately, that's what we're seeing across the province. So if you look at, here's a slide that's on a document out of the federal government called Flu Watch. And basically what it shows is this dotted line here is our average since 2014 to 2019 of influenza cases test positive as compared on average for those for that time period for those 5 years. I highlighted the area to see where we sit now, and you'll see technically, and this is 2-week-old data, this goes to the middle of October, we're technically just hitting the average. So one might think, oh, that's okay, we're at the average of the last 5 years. The problem is when we look at this line, most likely in the next when it comes out in about 2 weeks to get us to November, it's always a 2-week lag, that line's probably going to go shooting straight up or on that range as compared to this gradual increase. It's going to happen sooner than what it traditionally does, consistent most likely with what we're seeing in Australia. So you might say, okay, what are we doing to, what do we do to prepare for this? And a lot of this is old messaging, but to reinforce it, we've aggressively over the last 3 years hired frontline clinical staff and have over 400 frontline clinical staff, more than we had in 2019. We have 53 additional acute care beds open. 18 of them are still unfunded. We're still working on that. And as late as this morning, I had some calls on that. So hopefully that gets resolved very shortly. And I just pulled from an EMS report that was made public, and it's a good jump off to see where we're at. What we're seeing, and hospitals are seeing this too, is the raw volume of patients coming to the emergency department. The raw volume of patients using EMS is similar now, or possibly even less now, than what it was prior to COVID. We're not even back at pre-COVID, say, emergency room total volumes. The difference is when you peel that layer down, what do you see about those volumes? What is that patient coming in? What is the difference? What's causing this? So one of the things you got to highlight right off the bat is I wish we were doing 100% of the surgery volumes we did in 2019. I wish we were doing 130% of the surgeries we're doing in 2019. We're not. The maximum we're getting is 70. So what that indicates, though, is surgical patients are not sitting in the medicine beds where you can say, well, if you just reduced your surgeries to 100% of the 2019 volumes, you could find those beds. No, we can't. So we're doing as many surgeries as we possibly can based upon available beds. The difference between now and 2019 is back in 2019, we were admitting about 15% of the patients that were coming through the emergency room doors. Now we're admitting 20%. That's 5 patients a day. Not only are we admitting 5% more, but every single one of our patients, on average, close to 600 of them, are staying 2 more days in the hospital than they did in 2019. So what does that mean? That means demand on acute care beds. That wasn't there before. That is there now. Plus a raw number, we're getting about 5 more patients a day being admitted in the hospital on top of it than we had in 2019, even though the raw volumes total is less. This is consistent with EMS. So EMS is going out in the community, picking someone out of the house or somewhere else, at their house or somewhere else. We track their data to say, okay, out of the patients they're bringing in the hospital, are they sicker? Sicker by the basis of, are they being admitted at a higher rate? Sure enough, the number falls between 4 to 6%, on average 5%. So 5% more of the EMS patients being taken now as compared to 2019 are being admitted. So they're seeing sicker patients, which one would assume that when they're on the site addressing the patient's needs and putting them into the EMS to the hospital, it's going to take most likely longer because they're sicker. They don't track that data, but I think they're going to start tracking it now to see those time elements with respect to their journey if it's increasing. So all in all, that's why we have the issues we're facing right now. And I could pretty much repeat this presentation with different numbers for pretty much every single hospital in the province of Ontario, and I could probably stretch it to all of Canada. Very similar findings with respect to what we're seeing with respect to the patients. Some of the things we've done, this is just an example of 2 things, and there's a magnitude of different things we've done. But starting on October 1st, in our emergency department, the ER physicians really stepped up, and we have one in triage now. I'm at both campuses for those hours, 7 days a week. That's made a significant difference in addressing some of the issues we're facing and getting some of the patients seen earlier than they have in the past. At the same time, back in August, the internal medicine doctors came down to the emergency department and they started seeing patients in the emergency department to help out, as outlined there. And that's made a significant difference. And that's happening because they have other jobs outside of the emergency department. That's happening about 50% of the time. But when it does happen, it's making a significant difference to the system. We'll talk about vaccinations in a bit, but this is where I hand it off to Karen and Wasim. Dr. Saad is, this is what they're going to talk about. Is you hear about it, RSV, what is that? Influenza, kind of know what that is. COVID, we have an idea, but it's changed a bit. Who do they target or who do they impact? How can we avoid them? And if we acquire them, what do we do? Or what can we do? So I'll pass it over to Karen.